I'm going to talk to you about another window that's opened technologically speaking, whilst maintaining skills. So in keeping with the theme of MOACON, I'm going to talk to you about minimally invasive surgery for deformity correction in the foot and the ankle, largely based in the foot. We're all familiar with techniques that utilize open methods. There are well-established extensile approaches that we are familiar with, but we know that they cause significant soft tissue disruption. There's often the extensile nature causes vascular injury to the soft tissue integument, and this is something that we encounter on a repeated basis, particularly in hindfoot surgery. And we all know about the potential complications that you get, largely due to wounds, dehiscence, and sepsis secondarily. The philosophy of minimal invasion has been well established, and it's been there for decades. Arthroscopy being the prime example, where we recognize that using small incisions will respect the soft tissue circulation and therefore is likely to give you lesser complications. It's not just isolated to the orthopedic fraternity, but we know that it's used in the judicial systems, where you try and punish as less as possible to get maximum rehabilitation. But as technology develops, we find ever more increasing uses for technology, and that is part of surgical skill, is being able to choose your technology that would make your life as a surgeon easier. We are traditionally familiar with the open techniques, where we use a saw and we use a linear cutting process to make our bone division. It causes a very small amount of kerf. You don't lose much bone, but you can do it under direct vision, which is probably an advantage. However, in order to get direct vision, you need an invasive procedure. Whereas in the burr, the use of the burr in minimally invasive surgery involves a rotational cutting motion, and I'll show you what I mean by that. There's much more bone loss because the burrs are 2 or 3 millimeters thick, and you probably lose 3 millimeter cubed of bone as bone paste. However, the huge advantage is that you can do this indirectly, minimizing soft tissue loss. And so this is what it looks like. It's a pencil grip, so you get very good feedback from your instruments. You do require a selection of tools which employ the minimally invasive technique, and I think the mini C-arm is almost essential to avoid glowing in the dark after you've frazzled yourself to a crisp. So we don't use the linear translation using the burr, but use a rotational movement which allows you to work through a tiny window in order to effect your osteotomy. So let's look at the forefoot to begin with. You have the dorsal chylectomy. It's a very well recognized operation. We've all done it. It gives predictably good results, but you do have to make an open incision. You have to strap or brace the big toe in order to avoid deformity, particularly if you're using a medial or a dorsomedial approach. In the dorsal chylectomy performed minimally invasively, it's a 3 millimeter stab incision, and you create a working pocket. The patient walks out of the operating theater because you can do this under a block. You use the burr to take away the dorsal prominence, and you can get the patient to tiptoe within a week. And this is particularly useful in the kicking, the running sport, the elite athlete who wants to get back to training as quickly as possible. So the rehabilitation process starts very much earlier. And that's what it looks like. It's a really tiny incision. There are no sutures. And the cut that you get in the dorsum of the first metatarsal head is almost exactly like what you would get with a saw blade. You can use the same philosophy to work on the hallux valgus. I know that it's not very prevalent here, but I can guarantee you with the increasing use of shoe wear, you're almost certainly going to see a steep rise in hallux valgus, because I strongly believe that hallux valgus indications will increase with footwear. We follow the same principles. You use a minimally invasive lateral soft tissue release, and then you work your way through to cut a chevron into the first metatarsal. There's inevitably likely to be some length loss, and that's why you angle your osteotomy so that by translating it, you don't lose your length. You climb up the hill, as if you know what I mean. So the head will actually move distally so that it'll make up for the loss of limb length. You can also do an Aiken osteotomy to correct any valgus interphalangeus, again done minimally invasively. And you can get a very good correction. You can do that in mild to moderate symptomatic hallux valgus, but we've now extended the indication, so we do extreme MECAs where you have almost 80% translation, and we've got special instrumentation that would allow us to do that. Likewise, with significant metatarsalgia, those of you who have performed the Weil osteotomy or the halal osteotomy will be familiar with the problems of the floating toe, because you have to release all the collaterals. These are done minimally invasively. You allow the patient to walk on day one. You insist on the patient walking on day one so that the metatarsals will find their parabola comfortably, but without assault to the collateral system, which is what caused the problems in previous osteotomies. We've used that for multiple metatarsal osteotomies, and this has been published by me. I also use it quite extensively in treating a Taylor's bunionette, which again is almost immediate correction. As soon as you do the osteotomy shift will occur before your eyes because of the pull of the interossei medial to the metatarsal head, and you get an excellent correction. This has also been published last year. If we looked at hindfoot osteotomy, this MI technique has opened up a paradigm shift in the way we look at hindfoot osteotomies. We're able to do multiplanar osteotomies without opening up, again, using 3 or 4 millimeter entry portals. You can have angular corrections both in the sagittal and the coronal planes, but you can also do Zadok-type dorsal closing wedge osteotomies. You can do Dwyer's and a variety of other osteotomies. It employs the same principle. You use a burr instead of opening it all up like this. You then create your osteotomy, and then you fix the osteotomy. The beauty of the osteotomy is that because you lose 3 millimeters of bone, the osteotomy is extremely mobile, so you don't really have to open, you don't have to distract and wait for the soft tissues to relax before you move the osteotomy. So it makes it very much more easier to shift your osteotomy both medially and laterally. The eventual scar is very tiny, which again extols the virtue of this osteotomy. And you can see we can have huge shifts because of the mobility of the osteotomy. And this is an example of the Zadok, which I use for insertional Achilles tendinopathy to try and move the posterior tuberosity away from the tender Achilles, also resulting in some relaxation of the tender Achilles for recalcitrant insertional tendinopathy. It comes of its own when you have multiaxial or multi-segment deformity, particularly with open surgery like the Japa, where you have got to extensively dissect. What happens then once you excise your wedges, the foot shortens, you get unequal feet, you get lots of issues with scarring. So it's not the happiest of operations for what is a complex deformity. You're trying to convert a multiplanar deformity into a uniplanar deformity or a biplanar deformity sometimes. So let's take an example of this diabetic. You can see multiple calcific arteriograms. It's difficult to try and open everything. You inevitably will cause vascular injury. And you can actually do this completely through excising a wedge, but excising a wedge in a controlled fashion with virtually no scarring at all. So that's all the scar you have. You have a small medial portal of 3 millimeters, and you can excise large wedges and create very good segmental correction. In the 3D deformities, which are really quite the most difficult, I know Mangal is here. He does a lot of limb reconstructions for relapsed club feet, etc. You do have significant difficulties with poor soft tissue. A few surgeons have had a go, so it's a rather raped and pillaged foot by the time it comes to you. So taking an example of this is a Somalian taxi driver who wanted to get married and wanted to get his foot straight. Again, multi-segmental deformity. You can use the combination of a frame. I use the Taylor spatial frame. You do a V osteotomy, you rotate, you lengthen the os calces, You don't touch any of the soft tissues. You don't do a Steindler release. You don't do a tender Achilles release. The frame will do it all for you, and you largely effect your corrections through the osteotomies. And it does give you a remarkable correction. Again, another extreme example, very severe hindfoot deformity secondary to Charcot, complicated by MRSA sepsis. Patient had problems with the other limb, so the initial plan of taking the limb off was abandoned. So you can see that there's almost 100-degree rotational deformity. The foot is almost facing backwards with the ulcer on the plantar lateral side. The ulcer was cleaned up and dressed, and again, we did an osteotomy through the Chopard complex, utilized an acute correction by means of a minimally invasive osteotomy of the heel, and we managed to get a complete correction. So this again illustrates to you the power of technology when you combine it with judicious surgical thinking and planning. So in conclusion, it's an emerging technology and the uses are increasing exponentially. We now have the pediatric surgeons who look upon it like gulab jamun, where they think, my goodness, if I can do all of my osteotomies. So all of the intertrochanteric and femoral osteotomies now in a few centers in the UK are being done by the minimally invasive procedure. The indications are rapidly expanding. It is very ergonomically very friendly because you get excellent feedback from the burr, and the patient satisfaction scores that we've collected so far have been very, very encouraging. It does require a learning curve, and as part of the group that propounds the use of this, we insist on cadaver experience, at least 2 cadaver courses before we let the surgeon loose on a live specimen. And the evidence is emerging. I've published 6 papers in the last 7 months, all of them on MI surgery. But you do have to invest in some kit, in particular the mini C-arm, otherwise your radiation dosage will be quite astronomical. Thank you very much.